Hi, I'm Pete Secor, and this is Evergreen Telemetry by the numbers. 3, 2, 1, go!
Hi, I'm Charmaine. 3 is for our 3-year warranty.
Hi, I'm Colby. 3 is for our 3 different types of capture hoods.
Hi, I'm John. 3 is for 3D printing for rapid innovation of new products.
Hi, I'm Tony, and 2 is for our 2-week free field trial.
Hi, I'm Cole. 2 is for a 2-day turnaround on recalibrations. If we take longer than 2 days, it's free.
Hi, I'm Julie, and number 1 is you, our customer, which is our top priority. Everybody?
You're number 1!
Thank you for your business!
My name is Joe Moroni. I'm a certified commissioning agent and currently work for ECG Management Consultants as a manager with the firm. ECG is a management consulting firm focused exclusively on providing advisory services in the healthcare space. I work within the Facility and Capital Asset Planning Group, where we provide executive advisory services at the intersection of facilities and strategy. So without further introduction, let's go ahead and get started. I'm here today to talk to you about retro commissioning in healthcare. This course is being sponsored by the ACG and AIA and will be available for continuing education credit as applicable. There's a 10-question quiz at the end. So to provide you a little bit more about my background before we get into things too much, after graduating college, I spent the next 5 years in the Navy as a nuclear division officer. I served chiefly aboard the USS John C. Stennis, and after leaving the Navy, I started working for McKinstry Company based out of Seattle. McKinstry is a mechanical design build firm with a large commissioning group, and I was a commissioning engineer while I was there. We were based specifically out of McKinstry's energy practice, which focused on providing commissioning services within the existing building space. While commissioning engineer at McKinstry, I got my CxA and worked on a number of complex systems in both hospitals and other healthcare settings, as well as large complex hospital or college campuses and the like. So that's where I got exposed to retro commissioning in redesigning the way that existing buildings operate and helping facilities operators understand how to optimize their systems. While working at McKinstry, I also got my MBA at night, and after graduating, started with ECG a few years ago, and now using my commissioning certification primarily to provide advisory services to executives and facilities managers, and really understanding the intersection of strategy and their facilities. So to provide an orientation about what we'll be talking about today, why retro commissioning is so applicable in the healthcare environment, and in my opinion, probably better for healthcare than any other vertical market, I want to talk about really how this applies to the overarching changes in healthcare. And so that change is really in the way that care is being delivered and the physical environment that's required to deliver that care. I believe that COVID-19 has really accelerated and highlighted many of the changes that were already taking place, namely the shift from care out of the conventional inpatient setting into a more dispersed outpatient setting. So from a facilities perspective, what does that mean? What do these shifts mean? First of all, it means that new facilities will be built with greater flexibility in mind to meet these new challenges. And secondly, that existing facilities will need to be thoughtfully modified to flex with the changes in demand and alternative use. So COVID-19 provides another example of this. The operational changes that were made within many hospitals to convert patient rooms and other areas within the hospitals into negative pressure environments highlighted an immediate change in use that needed to happen within those facilities, and provides an example of a change which the retro commissioning methodology is a perfect example of something that retro commissioning can be used to solve. So today's course will provide an introduction to retrocommissioning, the context within the healthcare environment, and a high-level methodology for delivering retrocommissioning for a healthcare client. Really specifically, the methodology is for a hospital client. And the learning objectives of the course, first of all, by the end of this course, you'll be able to discuss the evolving trends in healthcare volumes and patient demands, and really understand the context of those changes, and be able to understand and speak to clients about those changes and what they mean for their facilities. Secondly, it's understanding how those shifting patient volumes will lead to demand for new, flexible healthcare spaces, and what that means for the changes in the types of physical environment that needs to be delivered for care. Third, you'll describe how retrocommissioning can enhance an understanding of asset capabilities. So this will be particularly valuable for facilities operators as well as other stakeholders within an organization. And you're going to hear me say this a bunch today, but it's about putting assets to their highest and best use. That's something that's very valuable that the retrocommissioning methodology can provide for healthcare clients. And the fourth objective today is understanding how to utilize healthcare terminology to describe the need for retrocommissioning and its benefits. So retrocommissioning introduces the commissioning agent to facilities operators at a time when their systems aren't working right, and when they need resources to make changes that have either been dictated to them by new requirements or changes in use within a facility, and being able to help the facilities operator communicate those changes strategically, communicate those changes within the organization to C-level executives is important. And that's another benefit that comes out of retrocommissioning, and something we hope you take out of the course today. So we already touched on this a little bit, but why healthcare? Why is retrocommissioning such a good fit in the healthcare environment? To us, we think that retrocommissioning specifically provides the tools to serve healthcare clients particularly well, and the reason is for these four reasons that are laid out here. So number one, healthcare facilities are complex and must evolve over their useful lives. And so that means that the way healthcare facility systems were designed is not necessarily the way that they need to operate today. And retrocommissioning provides an opportunity for an outside professional to come into a facility and help the facilities operators unwind how their facility is operating, understanding where it needs to go in the future, and help put a plan together to get there. Secondly, most facility systems have been updated over time with critical components value engineered out of final solutions. And this is particularly true in complex hospital campuses. I think many of us who have worked in healthcare have seen this. Multiple buildings on a campus built up over decades, where the systems are pieced together. Many have been taken out. Many are working in under capacity, over capacity, lots of different issues with those facility systems. On the surface, those facilities provide outstanding patient care. The buildings are put together very nicely. Those campuses are outstanding on the surface, but when you peel back the walls, when you get behind the surface, you see many of these facility systems are in pretty bad shape and require attention. So the third reason that retrocommissioning is really applicable to healthcare is that patient safety and provider preference require many systems to be operated continuously and often in an overridden state. So I would say perhaps every hospital that I have worked in, I've heard the facilities operators tell me that their OR air handling system has been overridden to some lower temperature because a surgeon dictated it. And those sort of changes and that sort of power dynamic within a healthcare facility ring true everywhere, and make some really specific challenges for operating the facilities the way that they need to. And fourth is that facility budgets are being squeezed by outside pressures from payers and facility regulators. So retro-commissioning provides a relatively low-cost way for facilities to have access to some really important high-impact solutions. So those budgets are being squeezed by payers, in other words, insurance providers, because reimbursement is going down for procedures. So you're being paid less as an organization for doing the same work as you were a few years ago. And on the opposite side, there's a cost increase for operating these facilities because of more stringent requirements, both in terms of the physical environment that's required to be delivered, as well as some of the administrative requirements of the facilities operators. They're running new programs. They're on additional committees, all because those are dictated by the Joint Commission and other sort of regulating bodies. So as a result of all of these pressures, you have complex healthcare facilities being operated with limited budgets and operators who are out of practice when it comes to dynamically operating their systems. So these facilities are complex, but the systems operate 24/7. They're often an override, and so even the best trained operators, 3, 4, 5 years after the systems were installed, there's a loss in knowledge about how those facilities operate. So the retro-commissioning agent is able to step into those facilities, help the facilities operators understand how the systems should be operating, and then make changes and position for the future. And so now that we've gone over why retro-commissioning is important in healthcare, I want to take a few minutes to drill down into the shifts that are taking place in the healthcare industry and talk about why those directly impact a facility. So this is important for retro-commissioning agent to understand the context within the industry, to better serve not only the facilities directors that you'll probably be working for, but also other people within the organization to communicate the value. So an overarching trend in healthcare is, again, a shift away from the conventional hospital setting toward more distributed ambulatory settings. This shift impacts patients and providers, and it affects facility operators as well. So as you see from the figure on this slide, this is all information from a 2019 white paper. And this demonstrates the shift from what we saw as the current healthcare environment in 2019 to the future healthcare environment. And again, COVID-19 really highlighted the fact that this future care environment is not in our imagination. This change is coming, and it's going to drastically shift the way that healthcare is provided. So what you see on the left here, first you see ambulatory care being 80% of healthcare, and you see these two tiny slivers on the left as well, with home health at 2% and digital health at 3% of healthcare. And on the right, you see home and digital health growing by substantially and really displacing a lot of the ambulatory care. But the other shift that you see is the change from 15% of acute care, which is hospital care, down to 5%. So that's a 2/3 decrease in the hospital-based care that's being provided. And that means drastic changes in the level of reimbursement, the level of revenue that hospitals and healthcare systems are going to achieve. And that means that they're going to have to provide care with far less revenue. And so what do each of these shifts mean for facilities operators specifically? Well, an increase in digital care means that this data is going to have to be housed somewhere. Many organizations are going to build new data centers, and the facilities operators are going to be tasked with operating those. So even if they are not trained as as data center operators. That's what they'll be doing, spending much of their time doing, and in all likelihood, it'll be doing that in addition to their other roles. An increase in home health will likely fall to the facilities operators in really working through the logistics of that, how to warehouse medical equipment and other things that need to be stored before they go out to a person's home, and then figuring out how to actually get those things there and maintain them, even within a person's home if they need to be maintained. And so that's going to be a new, unique challenge for those facilities operators. That displacement of ambulatory care by digital and home health, and to a certain extent acute care, from 80% of care now to 30% in the future, means that in all likelihood, these large outpatient centers may be things of the past, and that healthcare facilities, healthcare systems will be focused on getting out closer to where patients live to provide them care. And so that means for a facilities operator that instead of being in charge of 5 or 10 outpatient facilities, you'll be in charge now of 10, 15, 20 facilities. And how do you manage your workforce to get out to all of those facilities? How do you manage power outages and other disasters that affect large swaths of your area? And that's going to be a real challenge for facilities operators. So helping as a retrocommissioning agent, helping think through how to monitor those systems, how to continuously keep them updated so that there's less break fix, less windshield time, et cetera. That's something that's going to be hugely important. And last but not least, the change in acute care. So 15% to 5% means that hospitals are going to have less revenue, but it also means that the average patient in a hospital is going to be sicker. The sickest patients are not going away from the hospital. That's not what this is saying. Rather, that's the percentage of healthcare that they are, right around that 5%. So sicker patients in a hospital means that the facility systems that you have today are going to have to be adapted to provide more air changes, to have more negative pressure spaces. And that's really going to put the pressure on those systems, and it's going to put the pressure on the facilities directors to operate those spaces with that increased flexibility. And altogether, there's that increased flexibility. There's more efficiency that will be required and more cost effectiveness. Again, the revenue landscape is shifting. So being cost effective is something that's critically important. And by being, again, a relatively low cost service, retrocommissioning can help position facilities to better meet these challenges in the future. So thus far, we focused a lot on the why. Why healthcare? Why retrocommissioning? What's happening in the environment, and why is that important? And now we're gonna get into shift to talk about the what. So first, I'm going to give you an overview of retrocommissioning. So ACG provides a definition of commissioning in its guidelines, and says that retrocommissioning arises from a building owner's need to resolve ongoing problems or to ensure functionality continues to meet a facility's needs, and is an alternative to ad hoc efforts to mitigate recurring HVAC problems by offering a systematic approach to identifying and resolving issues or adverse conditions. So what's critical here is that we're talking about existing buildings and existing systems. So this differs from conventional new construction and commissioning very basically because you're operating in existing systems. But the other thing is that generally retrocommissioning applies when there's a problem. So there's an investigative component to retrocommissioning that also differs significantly from new construction commissioning. So what are some of the key activities of retrocommissioning? We have 6 listed here. 4 of these come from the ACG's guidelines, and the last 2 were added by us. So the first activity is identifying deficient system performance and guiding corrective action. So this is your conventional find it, fix it sort of activity, which is really most identifiable as retro-commissioning. Many utilities have incentive programs, have grants to help do this. This is your low cost, no cost fixes as well. So that's really at its core. When people think retro-commissioning, that's what it is. Second activity highlighted by ACG is determining deviations from intended design and guiding corrective action. So what's important here is that intended design does not equal original design. So in the healthcare environment, this is really important in distinguishing and something and something that really makes retro commissioning far different than new construction commissioning. Because of changes in the environment, facilities will have to operate differently than they did when they originally designed, and the commissioning agent will often come in front of the design engineer, in front of those professional engineers, to recommend those changes and determine how to implement them. And really, you're then back checking those changes against the codes and designs, et cetera, to make sure that it checks those boxes. But ultimately, it's an operational change that the retro commissioning agent is working on to really meet that intent where a facility needs to be. Third retro commissioning activity is identifying and detecting minor problems and identifying the correct remediation prior to problem escalation. So that's continuously monitoring and making sure the problems don't get out of hand. Fourth is obtaining or creating the necessary documentation needed to evaluate system performance. And as you might glean here, if the design of a system is changing, if the operation of a system needs to change, the retro commissioning agent needs to be able to define those changes and then write the test procedures for those particular changes. Also, in all likelihood, the documentation that existed from original design is probably lost or obsolete. So going into an operating system, determining how it is operating and defining that as well is something that the retro commissioning agent is going to need to be able to do. So documentation is of course a key thing that commissioning agents need to do, and it's no different here in retro commissioning. It's just you're often starting with a blank sheet of paper. So number 5, this one again was added by us. This is measuring a system's capacity against intended changes in use and implementing updates to those operating sequences. So again, the intended changes in use, the example again comes to mind with changing many of your patient rooms to negative airflow for COVID or for other sort of considerations, or increasing your OR air changes because of increased requirements. Those are the sorts of changes that we're talking about here, and in determining if the system has space to really do that in the field is something that you're going to be doing in retro commissioning. And the 6th one is training or retraining building operators on system operation and performance measurement. This is really one of the biggest value adds for retro commissioning in healthcare. You can convince the CFO to buy retro commissioning because it's going to save on operating dollars. But in my opinion, you can really convince the facilities director to buy retro commissioning services because they can figure out how their systems are supposed to be operating, and they can not only train them, but that they can train their staff on the dynamic operation of those systems. So you can make improvements not only today, but determine how to operate those buildings in the future. So in continuing to talk about what retro commissioning is, we're going to shift briefly from the definition that we went over, the perspective from the commissioning agent's side of things, and talk about retro commissioning from the owner's perspective. So retro commissioning really benefits, in my opinion, all stakeholders within an organization, but we're going to talk about 4 key stakeholders here today. So the first that we're going to talk about is patient care. So improved system performance provides a cleaner, safer environment that is more resilient and adaptable to future changes in patient needs. So that means more air changes, more negative air pressure rooms. But it also means more simply better temperature control, better comfort, identifying leaking dampers, broken valves, et cetera, that are causing those system issues, and fixing them to just tighten the way that systems are operating to provide that better care, the more comfortable care, care that's able to provide better infection control for the environment. That's critical, and something that retrocommissioning can really do to make some low-cost improvements in a facility to make it better almost immediately. Second group we want to talk about is finance. So sort of 2 big takeaways here for finance within an organization. So not only will retrocommissioning increase system efficiency, which will reduce operational spend, many retrocommissioning projects will provide access to grant funding or other capital sources. So many utilities provide incentives to perform these retrocommissioning activities, which are really critical in helping get one of these projects off the ground and get it sold within an organization. The third group that'll benefit within an organization is strategy. So a full understanding of the building and system capabilities helps strategic planners identify, again, the highest and best use of client assets. So this is where the retrocommissioning agent can really help the facilities operators first understand the capacity of their systems, the capabilities of their buildings, what can we do with what we have, and then take part in those strategic conversations about changing what types of patients are in which wing of the hospital, for instance, or what types of services are offered in this outpatient facility versus that outpatient facility, and being able to participate in that conversation and say things like, well, we have capacity to make that change here, but not here, so maybe we should think differently. And what that's going to do is potentially limit the need to do lengthy construction projects to change and not only provide capital dollars, but provide that patient care faster. And so that's something that retrocommissioning can really do and help benefit strategy within an organization. And last but not least, the facilities department will vastly benefit from retrocommissioning. So not only from improved system performance, but also increased stakeholder alignment with all of the stakeholders within an organization, making finance happy, making strategy happy, hopefully making your executive team happy. That's something that retrocommissioning can do. And it's also going to provide that refreshed training to enable facility stakeholders to benefit from those changes. So retraining operators on how their buildings are supposed to operate, training them on how they're going to operate in the future, and really just unwinding everything that's been going on in a system to help them understand the dynamic operations of the facilities, even if they've been overridden for years, even if they've been required to operate ORs at 64 degrees because the surgeon said so. So now, how to do it? There, as you might have gleaned from discussing all the various steps in retrocommissioning and the different stakeholders that it can benefit, there's more than one way to do the retrocommissioning process. Again, that's one of the things that makes retrocommissioning unique versus more conventional new construction and commissioning. So we've laid out a 4-step methodology here. That's a pretty basic methodology, but something that I think can apply to a lot of different projects. So the first step that we've identified is assessing current operations. So this involves activities such as reviewing system design against current operations, identifying the complex sequences or overridden equipment. So that's getting out in the field, looking at the BAS, the front end, and determining which systems are complex, or at least were designed to be operated dynamically. Determining the overridden equipment, finding the broken equipment, and then it's the third step here is performing targeted functional testing and field measurements. So this isn't the same thing as doing point-to-point testing and functional performance testing on an entire floor with 100 VAV boxes. This is doing the functional testing on the chill water system or the boiler system, or taking a look at interlocks and other things like that. It's finding the systems that are the most critical and of the highest value to a client, and doing just the testing on those systems. The second step that we've identified beyond assessing the current operations is one that's probably skipped a lot of times, but one that we believe is really critically important to making a retro commissioning project successful, and that is aligning stakeholder priorities. So within that, we've got a few different activities identified here. First is discussing current issues, budgets, and repair priorities. So this is getting out into the field first, and then sitting down to talk to the facilities director about the issues that you identified, the budgets that they have to make those changes, identifying those repair priorities. Second, it's determining the clinical limitations of each space and or system. So if you have a conventional med-surg unit that wants to be converted to, say, care for cardiac patients or for neuro patients, and that's the reason that that you were brought into a facility, can the systems that are in place actually meet those higher standards, really provide safe care for those patients? Or is there an alternative somewhere else within the facility that's maybe newer or has a system that's more dynamic that can meet those challenges? Third subset here is reviewing the key risks with senior leaders and determining strategic priorities. So that's getting in front of the CFO or the CEO or the chief nursing officer within a facility to talk about what you found, what some of the limitations of the spaces are, what you think can happen in those spaces in the future, and learn, well, what the strategic priorities are, how they're going to shift in the future, and really hopefully get the facilities director engaged and involved in those conversations. So this is probably in a retro commissioning project going to be one meeting, but something that is really critical and really going to add value for the facilities operators. The third step identified is back in the field, and that's refreshing facility standards. This includes updating control sequences to meet the new operational needs. Again, you're going to be in front of the professional engineer, in front of the design engineers in all likelihood as a retro commissioning agent. You may need to, of course, check those control sequences with the PE, but that's something that you're going to do is rewrite the standards. The second thing is recommending strategies to meet regulatory requirements. So new requirements have come out that require systems to be operated differently. How do you do that? Those recommendations are key. And then, of course, updating your documentation and training materials to get ready for implementation. The fourth step is implementation, so implementing those changes. It's overseeing repairs and updates and performing testing. So a lot of what I've talked about may have given the impression that the retro commissioning agent is going into a system, recommending changes, implementing those, walking away without much interaction with others. And really, it's quite the opposite. Retro commissioning, you have to be very closely involved, not only with the facilities operator, but also have a good relationship with some of the other key stakeholders. So the trades who are going to be making repairs, the controls contractor, who in all likelihood will have to come in to make the modifications to the system, and then write those sequences and test those sequences. So it's really being intimately involved, understanding how a facility operates, what changes need to be made, and being flexible with the field techs who are out helping you understand how those changes need to be made and implemented, and not being prescriptive necessarily in the way that those roll out. Second, in implementation, after that, after you've overseen those critical repairs and done your testing, is conducting your training. Very valuable for the facilities department, training all operators on that, and documenting the training, of course. And then last, hopefully you have a chance in the retro commissioning project to establish monitoring. So which points do you want to monitor? And then what are the feedback loops and the continuous communication that you have? So that last step, the monitoring and feedback loop, was the last step that we talked about, and that can really transition a retro commissioning project into something more like continuous commissioning. And so properly executed, a retro commissioning project will expand a facility's capabilities and become part of that continuous improvement cycle. So assessing current operations, aligning stakeholder priorities, implementing the changes, and then refreshing the standards. Doing that again and again if, say, there are some small changes that happen in the future, or if you help determine how to set up negative airflow rooms in a facility. They go back to normal operation, but in 5 years they have to convert back again. It's being able to implement those changes more easily in the future. So the long-term benefits of this, of course, are increased system efficiency, reduced operating costs, refined capital planning and budgeting priorities, increased space flexibility and optimization, and of course, improved patient care. So again, the retro commissioning process in healthcare is something that is very valuable and critically important. Retro commissioning agent is uniquely qualified to do all of this, and in our opinion, it's really quite simply putting assets to their highest and best use. And so with that, I want to thank you for taking the time to watch this training today. This concludes the course, and please feel free to reach out to me via email or phone if you have any questions or follow-up. Thank you very much. Appreciate your time.